Welcome, everyone. We've got another wellness webinar here for you as people join in, and we're getting the Facebook Live going. We're so glad to have you all here. And today we have a special presentation, Myths and Challenges about Evidence-Informed Practice in Complementary and Integrative Health, with Dr. Steffany Moonaz. And we are sponsored. She's at SCU, Southern California University of Health Sciences, who makes some of these webinars possible. So thanks so much to them. And quickly, as everyone's joining, I can share a little history about the Academy. We've got a long history here of all different folks joining together to bring a global interprofessional integrative health association to work to transform healthcare, body, mind, spirit, community, and planet. So we continue those efforts together, and we're growing. And another reminder, these webinars are recorded and they are on our YouTube channel. After they're finished presenting here, you can subscribe and get those and share those with your friends. There's always really great content on these webinars, especially today. Also, I want to take a moment to give a shout out to our fellows. Our fellowship program is accepting our 13th cohort this October, and we still have a couple spots left. I am the academic success manager, so I have the joy of working with the fellows through this 2-year, 1,000-hour program. And we are actually just beginning a special pilot project this October, where we're inviting nurses with BSNs or RNs who have a bachelor's degree in health-related fields to reach out to us and learn about this exciting new opportunity. So I will share that, and you can get in touch with us at those websites. And on to the star of our show here today. I get to welcome our special guest, Dr. Steffany Moonaz. She was appointed as Associate Research Director for Southern California University of Health Sciences. She's the chair for the newly formed Traditional World Medicine's Emerging Professions AIHM Council, as we merged with the Collaborative. Research focuses on the use of yoga and mind-body practices
I think maybe Jess had froze. Can you all hear me?
Yes.
Okay, great. So I will keep presenting Dr. Moonaz here. Her focus is on the use of yoga and mind-body practices for the management of arthritis and chronic pain. She's interested in health equity and access challenges and the relationship between chronic pain and substance use disorders. And she served as the had a little snafu there. It looks like we lost Jess altogether. There she is. Now she's back. Can you reshare those slides?
Yes, I'm so sorry. I got kicked out of Zoom.
Yeah, no problem. Sometimes we have these little hiccups.
Yes. Where did I leave off? I was talking, and perhaps I was, do you see the bio, or where was I?
I'm just finishing up the bio.
Okay.
So she served as the research director of Maryland University of Integrative Health, which developed the nation's first master's degree in yoga therapy. So Steffany, we're so thrilled to have you here. We love working with you, and I'm very excited about the topic today.
Thank you so much to Tabby and Jess and to AIHM for hosting this, and SCU for its support of AIHM. I'm going to share my slides here. Okay, so this presentation is on the myths and challenges of evidence-informed practice in complementary and integrative health. As was outlined in my bio, I have been involved in research now at 2 CIH focused institutions, and in those environments, I am a champion for research literacy and evidence-informed practice, and especially as an educator of students as well as a mentor of faculty, I have heard all of what I'm going to present to you in terms of the myths and challenges, the barriers and resistance to evidence-informed practice in complementary and integrative health, despite what we know the benefits also are. So this is the outline of the presentation. I'm going to start with that list of concerns. What people in the world of CIH perceive as the concerns and barriers related to evidence-informed practice. I'll give you a brief history of evidence-based medicine and evidence-informed practice, and then I'll demonstrate how evidence-informed practice is actually very well aligned with integrative health perspectives, how the use of evidence-informed practice shifts as both the evidence and the practitioner evolve. And then I'll go back to that list of common concerns and acknowledge where there is validity to them and also bust some of the myths where that's warranted. And then finish with just a note about evidence-informed practice for both research and practice. So here is the list of concerns. It's not exhaustive, but this is what I have heard the most. The reasons why evidence-informed practice either is not possible, is not important for CIH professions. One being that there isn't enough research. The research on CIH practices is too limited to be applied. The next is that research is reductionist by nature. The paradigm of research as it's conducted is a mismatch for the underlying philosophies of CIH practices. There are thousands of years of history behind my practice, and therefore, what do I need scientific research evidence for? There's sufficient anecdotal evidence to justify the practice. The biomedical model that underlies research does not understand my practice. So the way that research is conducted is asking the wrong questions or asking them in the wrong way. I value intuition more than I value evidence, and therefore the evidence is unimportant. Randomized controlled trials in particular don't work for my practice for a variety of reasons. The research is done wrong and doesn't reflect real life practice. My most revered teachers don't use evidence, so why should I? And lastly, I don't have the time or the skills or the access to research in order to implement evidence-informed practice in my clinical work. So I'm going to come back to those. I'm going to leave you hanging, and then I'm going to come back and share my thoughts about each one of them in kind. So you can just let them sort of hang in the air. And some of them you may share concerns about, and others you may be able to counter in your own mind as we proceed. So the history of evidence-based medicine, as it was originally called, is not actually that old. There was only the beginning of an alignment between biomedical science and clinical medicine in recent decades. So as clinical epidemiology was emerging as a field, and there was a growing body of evidence about the progression of disease and its nature, there was a recognition that that research was not being applied in clinical settings. And there are a few examples of situations where that misalignment was really prominent. An example being with pediatric rheumatic fever, where there was not any diagnostic criteria in a clinical setting to differentiate between two different types of pathology, which required two different courses of treatment. And that came out in the research literature. It was Alvin Feinstein, who was a mathematician and then a physician, who first suggested that there was a natural relationship here between that epidemiological data and clinical decision-making. And it wasn't until the late 70s that clinical epidemiology was even taught in medical schools. Not until 1981 did David Sackett from Harvard start to suggest that, in fact, medical doctors didn't have the skills necessary to take what they were learning in clinical epidemiology and actually use it in the process of clinical decision-making. So finally, a decade later, evidence-based medicine emerged in a team of Canadian and US leadership who decided that it was necessary to start training conventional medical physicians in the use of evidence-based medicine. In other words, not just teaching them clinical epidemiology, but teaching them how to take clinical epidemiology and apply it in clinical practice. It was recognized, however, at that time that the field of medicine outside of the medical schools did not have these skills. And so there was an effort by JAMA during the 90s to start providing continuing education to medical doctors so that they also could use evidence-based medicine. And then it wasn't until the early 90s that the Cochrane Group was formed, whereby rigorous systematic reviews could be conducted, and therefore the research on a given topic could be summarized and presented in a way that could be useful for the medical profession. So what is evidence-based medicine? We're going to switch over to calling this evidence-based practice, because evidence-based practice can be used by any clinician. An example would be that nursing can use evidence-based practice without practicing medicine, and to be more inclusive of the professions that might utilize these practices, we can call it evidence-based practice instead. It's defined as the conscientious, explicit, and judicious use of current best evidence, and that's going to be important, current and best evidence in making decisions about the care of the individual patient. It requires integrating individual clinical expertise, so what the physician knows and what the field knows from a clinical perspective, with the best available external clinical evidence from systematic research. So there are three pieces to evidence-based practice. And I think this is where the first aha can happen for CIH professionals. Evidence-based practice is not simply the application of whatever research there is to each and every individual patient without regard for other concerns. It is not evidence-based practice unless it has three essential ingredients. The first one is clinical expertise, and we're going to get into each of these in more detail to have a comprehensive sense of what it includes. But this is the expertise of the individual clinician as well as the field as a whole. Additionally, and this I think is also important from a CIH perspective, is that the patient matters. The patient's perspective, preferences, values, and concerns are an essential ingredient to the practice of evidence-based practice. And then lastly, the best research evidence that is clinically relevant and conducted using sound methodology. So it's not any evidence, but the best evidence that's available and relevant to the particular patient. And you'll see that I have citations listed at the bottom of these slides if you're interested in reading further. So can we combine the best of both worlds? So if we understand that we are certainly using patient-centered practice or substitute client, depending on your field, we want to also balance the science and our own experience. And these have different qualities to them. And because of that, there is some tension between them. So if you look at the bottom, for example, science can be a threat to physician autonomy, especially as evidence-based practice is starting to emerge and physicians may have a system of treating patients that is well understood to them, that they have been operating under for a long time, and then this new paradigm comes along that can feel threatening to the establishment. There can also be questions about who holds the power whether it is the publicly available information versus the privately held knowledge and expertise of the physician. And then how are we thinking about clinical practice, whether it's abstract or concrete, whether it's universal or whether it's personal. And I think these can exist in balance without siding entirely with the importance of one or the other. There's an expression called clinical jazz, and it suggests the art of medicine as well as the science. Robert M. Persig from Zen and the Art of Motorcycle Maintenance said, the real purpose of the scientific method is to make sure nature hasn't misled you into thinking you know something you actually don't know. So our own experience and observation can be biased and can lead us to believe that we know things for sure that may be called into question when we have a more objective picture of a larger available data set. So can we take the science and apply that in clinical practice without losing the art? Jazz, I think, is a nice analogy because jazz has a structure. There are rules to jazz, there are scales, there is phrasing, and yet the structure is not rigid. The structure is a framework, and it allows for play, for art, for improvisation to happen within and around that structure. And so if we think about that as science and expertise, we can take the structure, the foundation, the data available from science, and then we can use that to make art, to improvise, to practice medicine using our own expertise. And ideally, of course, that is all applied through a patient-oriented or client-oriented perspective so that we're looking at outcomes that matter to the people that we're working with, which may be different from the outcomes that matter to scientific investigation. This three-legged stool is, so there are different terms that are used for these three different pieces, but as we've laid out, there's clinical experience or expertise, there's the patient or client preferences and values, and then there's research evidence. And so we can say where all three of those are combined, where all three of those ingredients are utilized, that's where evidence-informed practice resides, in the center of that Venn diagram. That is the clinical jazz. Now, the concerns that CIH professionals may have are not new concerns. These are some of the concerns that existed from the medical establishment as the field of evidence-based medicine was emerging. So one concern was what was being expected or demanded of medical doctors. So medical doctors are now required not only to be able to assess the quality of the evidence in order to discern, remember I said it's the best available evidence that should be applied, which means that the medical doctor has to be able to assess the evidence to determine what the quality is. And then how do they apply it when the existing evidence may be suboptimal? And remember, that reflects one of our initial concerns on the concerns list, which was there's not enough research evidence. So the same was said in the field of conventional medicine early on. The next is that clinical decision-making is already complicated. There's a whole lot that goes into making clinical decisions, including gathering data about the individual patient, years of medical knowledge, experience, intuition that's brought to bear. And now you're going to add on top of that the expectation that we're going to draw in systematically gathered research evidence and bring that as yet another ingredient into this already very complicated process. Another concern was that that using the evidence would become an algorithm. So instead of medicine being individualized and each patient getting proper consideration for their uniqueness, that somehow this would become an algorithm where the science gets blindly applied to every patient, regardless of their unique circumstance. Additionally, while summary research was growing at the time, so that's systematic reviews, meta-analyses that allow us to look at the collective high-quality evidence related to a particular question, summary research is not always the best available evidence. There are examples of situations where there is no summary research for a particular question or population. There are some times where the summary research is inadequate and where there may be single studies that may be important to apply that may not rise to the level of rigor on the hierarchy of evidence. Okay, so I'm going to just take each one of these three buckets and outline a little bit further what I think falls into this category so you can start to get a more comprehensive idea of what this includes. So when we talk about expertise, and sometimes this is labeled as experience, but I think experience is inadequate because expertise includes not just what the individual clinician knows, but what the field of clinicians knows. So an individual clinician has learned from mentors, but there are also colleagues out in the world, leaders in the field who have years of experience and their own training and their own expertise that falls into this category. So learning from others, consulting clinical perspectives is a valid use of this category of expertise. Personal experience, so what an individual clinician has learned in all of their years of working with patients and clients. Of course, their training, including their initial training in the medicine and then continuing education, both formal and informal. The founding philosophy of the medicine. So I think this is particularly relevant for the medicines that are ancient and that have an underlying philosophy that is part of millennia of collective expertise that's important to the practice of the medicine, as well as the historic texts, not only the original texts, but also the texts throughout history related to the medicine that can be a picture of an accumulation of expertise over the history of the medicine. Intuition, which was mentioned as a critical ingredient in the practice of conventional medicine, as well as industry standards, which may be informed by evidence, but are also informed by expertise. Things like consensus papers that involve a variety of experts from the field, Delphi findings, which are a form of research, but they're a form of research that gathers expertise and then presents it in a systematic way. And then through theoretical papers that, that may use expertise in the field and present it from a particular vantage point that wouldn't rise to the level of being research evidence. And then come preferences. So these are what the client or patient brings to the encounter, what matters to them, which absolutely should dictate the choices that are made in the clinical encounter and in the care plan. What the concerns of the patient or client are, what matters most to them to be addressed, what do they most hope to gain out of the therapeutic relationship, their priorities, what their beliefs are, including what their perceived benefit or the perceived risk of a particular approach, what they're concerned about, what their quality of life already is. And so where their quality of life may be particularly impaired and worthy of bolstering, or where it may already be considered sufficient and balanced on the part of the patient or client, and therefore less of a priority. What particular symptoms they may be experiencing, which for a certain diagnosis can vary quite dramatically from one individual to another. What they have access to. Too often, we might make recommendations for patients or clients that are beyond their access for a variety of reasons, geographic or resource or information. What their lifestyle is now and what we may be recommending and how far of a departure it may be from their lifestyle, which is of course related to access, what their daily activities are and how this plan of care is going to fit into their lives, and then the support that they have or the caretaking responsibilities that they have, which are part of their relationships, and the whole system in which the care plan has to fit. So all of this gets considered in evidence-based practice because we want to practice patient-centered, client-centered care, whether that's in conventional medicine or in CIH professions. And then lastly, of course, the evidence. The evidence being defined as the available body of facts or information indicating whether a belief or proposition is true or valid. So we are not suggesting through the model of evidence-based practice that anyone take a particular research study and use that to change the way that they provide care to patients and clients. But the evidence can be a factor to consider, depending on the relevance of the evidence to that particular patient or client, the strength of the evidence, and the feasibility of its application in that particular circumstance. And so evidence is very broad. And if we think about the evidence hierarchy, it can include things from case reports up to meta-analyses. And as I had said earlier, it isn't always the systematic review or meta-analysis that is the strongest available evidence. It's also not always the most relevant evidence to a particular question or a particular patient-client situation. And I'll get back to that in a moment. So what is the difference between evidence-based medicine and evidence-informed practice? Because you may hear evidence-based medicine, evidence-based practice, evidence-informed practice. What are these different terms? Well, they're all the same thing, essentially, is the bottom line. As I already stated, we want to use evidence-based practice instead of evidence-based medicine. So the P versus the M in order to be more inclusive about who can use these strategies. But then the I emerged, replacing based with informed because of its connotation, not because of any actual difference in practical application. Evidence-informed practice is perceived to be more flexible. So we already laid out that evidence-based practice includes all of those three ingredients of the research evidence, the collective expertise, the patient or client preferences. But evidence-informed practice suggests that the research isn't most heavily weighted in that formula. So evidence-informed practice might suggest a heavier reliance on patient preference and expertise than on the research evidence. It also looks to the evidence as non-hierarchical, so it may draw from something like a survey as a valid source of information to apply rather than requiring that it be a systematic review or meta-analysis. The evidence-informed practice term seems to suggest more patient-centeredness, but by definition, evidence-based medicine is patient-centered also. I include this chart here or table rather, just to demonstrate how different research questions are answered by different research methodology. So for example, if you are interested in what the patient experience is of a particular treatment, then you're not necessarily looking to a meta-analysis to answer that. You might be looking at a qualitative study that's going to have text of the narratives from individual patients to get a sense of what their experience is like. If you want to understand the cost effectiveness of a particular approach, then you're going to look to an economic study rather than a clinical trial, which may not answer questions about cost effectiveness. So depending on your concerns with a particular patient, client, or population, you may want to be looking to different types of evidence. And this is why we tend to think about evidence as not being a hierarchy, but more being like a house with different rooms in them that serve different purposes. Now, how do we actually practice this? What does this look like? Well, the first thing that you do in order to engage in evidence-informed practice is to start with the patient or client. So you want to conduct an assessment to figure out what the concerns are, both your concerns as a clinician and their concerns as a patient that might need to be addressed through the therapeutic relationship. You then consider what would be the evidence that would be relevant to what I have gleaned from that assessment. And so you build a clinical question that's based on the case that's presented to you. And then you seek out the evidence that is relevant to that question. And so, as I said in the prior slide, the evidence that you're looking for depends on the question that you're going to ask. So being able to formulate an appropriate clinical question is a key skill here. And then being able to acquire the relevant evidence is important as well. And that's partly where access comes into play. And then this is the concern that came up in the field of medicine early on, was the necessity to appraise the evidence and to determine, is this relevant to the case? Is it valid? So is it sufficiently rigorous methodologically? And also, is it relevant to this particular client or patient? And in terms of feasibility, can it even be applied? And then there's the application. So you bring that evidence back to the patient or client, have a conversation about what your thoughts might be, combining what you gleaned from the research and what you know already as an expert clinician, and then develop a plan that considers all three of those components. You're not finished at the application stage, because then you evaluate to determine what the effects were of that application and then adjust accordingly. And so the cycle begins again. So this is the process of evidence-informed practice. In order to do this, you need two basic sets of skills. One, you need research literacy. So you have to be able to understand the research that you're reading, determine whether it's valid, look for what forms of bias there might be, understand how much weight to give it, and then consider a particular piece of evidence in the context of the larger body of existing evidence. So that's one skill set, and that's a skill set that we teach at CIH institutions so that our students have basic research literacy skills. But that's not enough, because then you also have to have the skills of clinical application. So if we're teaching research literacy in our didactic courses, then the clinical application needs to be taught in the clinical setting, in the clinical education, which is, how does this particular piece of evidence apply to this particular patient or client? And so that's the relevance, that's the feasibility of applying it, how to do that jazz making of combining what you gleaned from the evidence with your own expertise and what the patient values are, and ultimately determining whether the evidence that you see, or which of evidence you see, is worthy of application to the way that you think, to the way that you teach, or to the way that you practice clinically. It is important to note that the hierarchy of evidence, that pyramid, does not consider the quality and relevance within the category, right? So not all systematic reviews are conducted equally. And so not all systematic reviews are equally strong and rigorous. The same could be true about a clinical trial or survey research or qualitative studies. There are high quality studies within each of those categories. And so being able to appraise a particular study or a particular piece of summary research is necessary in order to make decisions about how it should be applied clinically. Also, there have been some individual studies that have led to groundbreaking changes in the way that medicine is practiced. So those who've been around for a little bit may recall how a single study of hormone replacement therapy seemingly overnight completely changed the way that hormone replacement therapy is used and practiced, what the best practices are for that particular medicine. And that was not a systematic review or a meta-analysis, it was a single clinical trial. So from this paper from 2014 from Wound Care Canada, it states that although individual research studies can be sought and appraised, most clinicians either do not have the time or do not have the expertise to find and appraise research studies. Therefore, a good choice for clinicians is to locate synthesized clinical information, so individual studies that have been appraised and combined following a rigorous process, such as best practice guidelines or systematic reviews. So it is absolutely true that systematic reviews and practice guidelines are more practical. And so what's possible is that experts in the field who have an understanding of how to evaluate the literature can do the work for the clinicians and make it available through systems such as UpToDate, which is common for medical providers to use. All right, so now let's get into alignment. How do each of these three legs hold up to the underlying philosophy of CIH practices? Where is there alignment or overlap in these perspectives? So when it comes to expertise or expert opinion, many of our medicines teach a respect for teacher. We often have training through apprenticeship or mentorship. And so that's well aligned with this bucket of expertise that includes the lineage that came before us that we consider when we're making clinical decisions. There is also the concept of experience as a teacher. So as we work with patients and clients and we gain our own experience, what we have learned through those experiences is brought to our clinical practice. Some of our practices are lineage-based, where we have a revered teacher who has their students and those students become the teachers for the next generation. And the concept of wise elders, as well as our intuition as being important. And I think it's interesting to note that that was also important for conventional medical providers who were considering the use of evidence-based medicine, that intuition needed to remain a key component of that practice. There's also the idea in some of our medicines that the practitioner is not the doer of the medicine, but a channel for the medicine, for healing, for energy that might move through them. And the concept of expertise can actually align with that idea that it's coming through me and not of me, that I'm not the expert, but I am passing on the medicine, the therapy, the healing, the teaching. It's also well aligned with mindfulness and present moment awareness, that we're not overthinking the work, but that we're allowing our discernment in the moment to guide decision making. And that is similar to intuition, but a slightly different concept. And then patient preference, of course, there's a strong value for patient-centered, client-centered practices in CIH medicines, which includes the skills, the value of active listening as part of the therapeutic relationship, having compassion and empathy, allowing the patient or client to harness, to bring forth the healer within, to hold space for the healing process that occurs within the patient or client, considering the client to be, in a sense, the world's leading expert of their own experience, the world's leading expert of what it is to be in their body and mind, and respecting the autonomy of the particular patient or client in co-creating or even in leading the therapeutic process. And then lastly, evidence, which I think is, oftentimes the stickiest for CIH professionals. There are lots of ways of knowing. There are lots of different kinds of evidence. And I think moving beyond the systematic review, or even moving beyond the randomized controlled trial as the only valid or useful form of evidence, may help us to embrace the concept of evidence-informed practice. We have skills of observation that we use in the practice of our medicines that is aligned with the skills of observation that a research scientist uses, that detached wisdom, the observer of the mind body that steps back and sees what's happening from a place of non-attachment. That's what we aim to embody as research scientists, and that's also something that some of our practices embody as well. Being discerning, having discriminate knowledge, an emphasis on our collective understanding, right? So expertise is often brought to bear for the individual, but there's also this whole collective understanding of general trends and patterns that can help us to make wise choices. We want to practice non-harming. Many of our medicines have a particular term for non-harming that is foundational to our medicine. And having research evidence can aid us in making decisions for clients and patients that are non-harming, because we can learn from safety data. We can learn from adverse events data in guiding right decision-making. Having an open mind. So not being so rigid in our thinking, so rigid in the way that we practice, that we can't learn, that we can't consider, that we can't look at another data set and consider it in informing the choices that we make. And along with that, our willingness to continue growth and expansion of ourselves and of our medicines. So interestingly, there's some data to suggest that the way clinicians use evidence-based practice depends on where they are in their evolution as a clinician and where the evidence is for their particular field. So I want you to consider this analogy of the three-legged stool and consider what you would do if you were sitting on this stool and there was one leg that was very strong and one leg that was very weak. Of course, the answer is that you're going to lean into the strongest leg. You're going to put more weight in the strongest leg. And as it turns out, that's exactly what happens in evidence-based medicine. So when a medical doctor generally is early in their journey, when they are freshly trained and have not collected a lot of clinical experience yet, they tend to lean more heavily into the research evidence because it's stronger than their own personal experience. Whereas as they grow as clinicians and as they get more experience under their belt, they tend to lean more heavily into their own experience than the research literature. The same can be true of the research leg. When the research is undeniably strong, there may be a heavier reliance on that evidence than when the research is not as strong, and it might be considered, but also taken somewhat with a grain of salt. And lastly, you all know that sometimes a patient or client comes in with very strong values, very strong perspectives, very strong ideas of the direction that they want the care to go. And there are other times that a patient or client comes in and really defers to the clinician. I don't really have a strong opinion here, so I'm happy to go with whatever you recommend. And so you also want to consider how strong that leg of the stool is. So evidence-informed practice necessarily includes all of these ingredients, but it can include them to different degrees in different proportions. So it's important, as someone who may be skeptical of evidence-informed practice, that it isn't necessary to rely very heavily on a leg of the stool that doesn't seem to warrant the weight. All right, so I'm going to come back to the concerns that I laid out at the beginning and try to quickly address them. And I think much of this I've shared already. So the first is that there isn't enough research. So I think in some cases there may be more research about a particular CIH field than you realize. So there are misconceptions about the volume and the quality of evidence in CIH fields. And there may be strong evidence in one particular area of the field and not others. Remember, I said sometimes there's a single study that's strong enough that it warrants informing clinical practice. And as the medicine grows, there may be periodic summaries that help us stay up to date with the evolution of the medicine. Additionally, if you believe that the evidence is not strong enough in your field, do things to help make it stronger. So get involved as a clinician, bringing the clinical perspective to the medicine, especially to make it more relevant to clinical practice. The next is that research is reductionist and CIH practice is holistic. Yes, it's true. Some research is reductionist, and reductionist research can answer important questions that are very specific. But reductionist approaches to research are not the only approach to research. When we want to understand the mechanisms, how something works the way that it works, we want to use a reductionist approach. But when we're trying to understand the medicine as a whole and how it functions in the real world, there may be other types of research that are better going to guide our decision-making. And this list identifies some of those that may be particularly relevant to clinical practice in CIH. I don't need research when there are thousands of years of history behind my practice. And so I ask the question, those thousands of years, did those bodies function the same way that our bodies function? And I don't mean biologically, I mean in terms of lifestyle and the way that we use our bodies in modern day. The amount of sitting that we do, the amount of time on screens that we have, the kinds of activities that we engage in. Do we want to consider how those practices apply to our current lifestyles? And are the practices being delivered now the same way they were then? An example might be, does your medicine get delivered daily between practitioner and client, or is it something that now is practiced weekly, whereas historically may have been at a higher or more concentrated dose? Is the context for the delivery of the medicine the same? And has the practice changed in those thousands of years because our medicines continue to shift over time? So we want to consider whether it's worth looking at our medicine now while also considering the entire history of the practice of our medicines. The biomedical model doesn't understand the underlying mechanisms of my practice. Again, get involved, because the more we as CIH practitioners are at the table making decisions about study design, about funding mechanisms, about peer review, we can steer the research in the direction of being more relevant to the way that we practice. Intuition is more important than evidence. I want to remind you that intuition is part of the evidence-informed practice paradigm. It fits under the arm of expert opinion. So you don't have to choose intuition over evidence. You can use both intuition and evidence to inform decision-making. Also, the patient is bringing their intuition to the patient perspectives category of the process. It's also possible that some of your intuition is informed by the research, and that research functions in part due to the intuition of the researchers themselves. So it doesn't have to be an either-or situation. You can also use your intuition to decide how you're going to apply evidence in part. Randomized control trials. Yeah, randomized controlled trials were designed for drug studies, and not all medicines lend themselves to a randomized controlled trial format. But there are lots of other types of study designs that may be more relevant. And it's possible to reconsider the randomized controlled trial by being mindful about the comparison groups that we use in order to answer useful questions about our medicine. The research is done wrong. It's not reflective of real-life practice. Again, become more research literate so that you can be discerning in your application of the evidence. Look to the types of study designs that are more relevant to the way practice happens. Get involved in research so that you can steer it toward more relevant study designs, and in peer review and in study sections, so that we can have a body of evidence that is more useful in informing evidence-informed practice. My revered teachers don't use evidence, so why should I? Well, in part, your teachers may not have had access to the same evidence that you have access to now because the evidence has grown. And also, if we continue to say, I'm only going to do exactly what my teachers do, then that may limit the opportunity for our medicines, our perspectives to grow. Evidence also is useful to promote greater acceptance of our medicines, which means more referrals, more collaboration, more interest in and utilization of our care, and even changes in policy that can drive improved access. And lastly, I don't have the time, skills, and access to implement evidence-informed practice. This is real and important. There is summary research. As I said, it's not always strong and it's not always current. There are aggregators like UpToDate. They're not always relevant to CIH and they may be very costly. Research literacy and evidence-informed practice belongs in clinical training from the beginning all the way through. And that's not always the case. And so we look to continuing education in some cases to fill that gap. So those of you who are educators or those of you who are designing curriculum, consider how you can weave those skills throughout the process. And let's prioritize open access publication so that the literature can be available to people who may not be affiliated with an institution. And let's try to share our research with others in the profession so that it may be used in evidence-informed practice. So to summarize, research is iterative. It keeps growing. It builds on itself. And evidence-informed research can build on what came before to confirm it, to elaborate on it, to clarify it in the same way that clinical practice evolves. So these two can inform each other. Research and clinical practice can inform each other by improving awareness of a concern, what patients' experiences are, communicating with our patients and clients, working together as collaborators, clinician researchers who use their clinical background to inform the research process, using the evidence for the development of practice guidelines, practice-based research that draws from practice and turns that into evidence, observational studies that look at the way that clinical practice happens, and then interprofessional education so that we can all learn from each other. There has always been an art to medicine. Evidence-based medicine is actually relatively recent in order to align science with the art of medicine. And evidence-informed practice uses a non-hierarchical approach to evidence. We need research literacy and clinical application skills in order to engage in evidence-informed practice. But there are very real barriers in CIH, including perceptions of research, time, and access to the evidence. Research evidence is aligned with patient values and clinical expertise. It doesn't usurp them. It's part of the equation. We can also include ancient teachings, wise mentors, and intuition within the framework of evidence-informed practice without relying too heavily on one leg to the disservice of a patient. This clinical jazz is aligned with best practices in integrative health, and research and practice can grow together to optimize both. So I will stop there and see if we have a few questions that you might like me to answer. Okay, so David Riley is sharing in the Q&A a quote from David Sackett in 1996 that says, "The practice of evidence-based medicine means integrating individual clinical expertise and the best available external clinical evidence from systematic research with patient preference." Yeah, so I think, unfortunately, in the world of CIH, there's a misunderstanding of evidence-informed practice as being just taking the research and then making clinical decisions based on the research alone without realizing that this is a three-pronged model that adds the research evidence to what we already do, utilizing clinical expertise and patient preferences. And to leave that out is a disservice to the people that we work with. If we're going to ignore an entire body of medicine about our entire body of evidence about the practice that we're using, then that's a disservice to the people who seek our care. What is the evidence for intuition? That's a great question, David. Jess, did you say you wanted to answer this live?
No, I'm just clicking that to let you answer it live. Thank you.
So I am not well versed in evidence related to intuition. My suggestion is that intuition belongs in the expertise category of evidence-informed practice. I wouldn't say that intuition is evidence, although there very well may be evidence about the usefulness of intuition, but I haven't explored that that research.
I think that one resource for that would probably be the Consciousness Healing Initiative that Dr. Shamini Jain heads up, and they're a member of AIHM. They do a lot of all the research, really the major research in biofield medicine has been brought together by that organization. And I'm sure that they would have some resources for that.
So there's another question in the chat that says, what is your response to open-minded EIP conventional providers who want to bring more CIH practices, but face skepticism from the medical system? In particular, a barrier I face is lack of drug interaction data with supplements and herbs and lack of standardized practice guidelines for CIH. Can you recommend sources to address this challenge? Yeah, this is a great point. So the medicines that I use are all in the category of mind-body practices. And so I don't face the same issues with looking at drug supplement interactions. There is some data about those relationships, but it's inadequate. And that's a serious concern. And so my suggestion is that we fund research to look at drug-herb interactions, and we fund projects to collect data about drug-herb interactions. But with regard to skepticism in conventional settings in general, I do the work of gathering the best available evidence and presenting it as a case for the safety, the acceptability, and the effectiveness of whatever the medicine is. So for example, in my work as a yoga therapist who works with people who have arthritis and chronic pain, if I am interested in working in a hospital setting, I will gather relevant evidence about, and the highest quality evidence, and they care about the pyramid, right? So the higher I can get on the pyramid, the larger the sample size, the bigger the data set, the institution where it was conducted, the journal that it was published in. I look at all of that when considering what research to call the most relevant, up-to-date, and present outcomes that they care about, which are objective measurements, ideally measures of disease activity, rather than patient-reported outcomes that I may really care about, but that may be unconvincing to a hospital administrator. So I'll say, here's the evidence that I can present to you about why this is safe and it's effective, and here are the outcomes that it's associated with, and this is why you should consider implementing it, which requires that I have those skills of research literacy and clinical application to be able to decide what's relevant and is going to be compelling to them. Yeah, unfortunately, generally the onus is on us to make the case rather than the other way around. How about the scope of practice that, for example, an acupuncturist can diagnose but not claim to cure disease? This seems to back the legal requirement for evidence-based randomized controlled trials that medicine actually works and can cure certain diseases. Yeah, so the more research evidence that's available, the more it can inform policy decisions. And so if you have concerns about scope of practice for a particular medicine, the way that you change scope of practice is by making the case for a change in that scope of practice, or what claims can be made about a particular medicine is related to the quality of the research that we have. So again, another reason why We want to grow research in these areas, and we also want to grow it in a way that is clinically relevant. So what are the questions that you think need to be answered about the medicine so that the research in CIH is not driven only by career researchers or by federal bodies, but is also driven by the people on the ground who are doing the work?
I want to thank everyone. We've actually run out of time, and I just want to thank you, Dr. Moonaz. This is absolutely the best. On this topic, I've never seen a presentation done so well. I so appreciate you coming and doing this, and I want to thank SCU for their sponsorship of this webinar and of so many things that we do at the Academy. Southern California University of Health Sciences is really one of the most cutting edge universities that is really working in the interprofessional education space. And I highly recommend, if you're looking into joining a program, becoming a health professional, to check out SCU. Their team is just phenomenal. And it's great to see you there as part of that team, Steffany. Just to finish up, I do want to let everyone know this is super exciting. We are inviting nurses with BSNs or RNs that have a bachelor degree to join our fellowship. We have a pilot project for nurses. This is the first time a fellowship of this level will be available to BSNs or RNs with bachelor's degrees. So if you're interested, let us know. We have special pricing for anyone who is interested in checking this out. And we have a cohort coming up in October. So we'd love to have you join. I'd also like to invite all of you to our upcoming People, Planet, Purpose conference, which is on the disruptive innovation and the future of health. We're going to have really amazing keynotes. This is the first time we'll be back in person in 2 years, and we are so excited. The hotel is already sold out. We're almost sold out of registration. So if you're interested in coming, please sign up now. It's going to be a really amazing 3 days. And we have a leadership day before organizational leadership meeting that we would love any of you who are our organizational members to join and be a part of that conversation. Please consider joining the AIHM community. If you're not a member yet, that is how we can do all of this work. And we really have a fantastic global community working in integrative health to change medicine and healthcare on this planet. So please come and join us. And finally, just if you want to connect with us, we are available online on all the social media channels. Our handle is AIHM Global. All of these webinars, you can come to our YouTube channel. They're all there for free. And for those webinar presenters who share our slides, those are available for our members in our members only platform. But you can find us in all the different places and join a chapter. We have great chapters all around the country and the globe. If you want to connect more closely with integrated providers and keep joining our community and be a part of this. Thanks again to Dr. Moonaz and to the whole SCU team, and we hope you have a great weekend.